It's 4 minutes past our meeting time, and I think we should go ahead and get started. Uh, Welcome everyone to the PACIO weekly meeting. Today is Wednesday, April 2nd, 2025. On our agenda, we'll have our regular leadership updates and subgroup updates, and after that, we'll continue our USCDI Draft V6 comments review. Uh, Without any, I think I forgot to check is there any new people we should welcome, but I don't think so. And I will, without further ado, I will pass it to Dave to provide the leadership update.
All right. Thank you. All right. So it is April. Hard to believe. Use cases are pretty much, tracking according to plan. The gray mark continues to march to the right. Transitions of care is about to enter ballot. We've got advanced directives STU2, which we're really, I think, making very good progress in getting ready for that for September ballot on that front. On personal functioning engagement, we are wrapping up reconciliation and going into the publication process. So those are the three items that are actively being developed at the moment. Standardized medication profile was just recently published, and we're still looking for ways to move that forward. And so, there is, digging into a little bit, we ran into a few minor issues getting the transitions of care stuff published, and I think that's affecting SMP as well, the standardized medication profile. Their HL7 seems to be working with a new publication system, and that is there's some errors that they're running into during that process that we don't run into when we're preparing the stuff for publication. So I think they're kind of working through that. And so they were able to work through it on transitions of care, but they're still having some issues with standardized medication profile. What we were seeing, at least from the error messages that HL7 shared with me, is that some of the pathways to files and things like that were getting messed up. And so files couldn't be found. And so the IG publisher was basically throwing up errors. um, and so we're just sort of, working through that. But, we don't have direct access to that process. So we're just kind of helping it out from afar. Uh, we will be continuing to you know, talk to Jeff Racone and all about, how do we move forward further on this? As I mentioned last time, the original funding stream was only for STU1 development. So, what does that look like going forward? And what is the new functionality we want to provide? Certainly, there were some learnings from the January Connectathon. So it could be fairly minor changes, but we want to also consider what we can do there. So that's kind of where we are for standardized medication profile. It's really just working through those publication errors, and then it will actually be officially published. We went through all of the various steps, and that's all been done. So we have a number of upcoming conferences. And so the American Nursing Informatics Association actually occurred this past week. The AMIA, excuse me, AMIA 2025 Clinical Informatics Summit. That's May 20th to 22nd. The HL7 WEDI Person-Centered Care for Healthier Communities Forum has been sort of touch and go. It was originally scheduled back in February, and that was sort of postponed, and so now it's looking like July 8th and 9th. So they've asked PACIO to present. It's a virtual event, and so we are sort of working with them to see what we want to present there. I think, Linnell James of the Blue Cross Blue Shield Association has been very heavily involved in that and creating that, along with others, and is really very, very keen on letting that community, the participants and the attendees of that workshop to know what is happening in the fire standards market. So it might be a really good opportunity for us to, get further traction on some potential pilots and things like that. And so, we'll be seeing and working to see what we can do there to maximize that possibility. And then there's the American Health Information Management Association annual conference in Minneapolis. That's October 12th to 14th. We have submitted an abstract for that. So, yeah. Uba, is there anything else that I should be talking about here?
There's a plan to submit to the speech language pathology meeting. The deadline is tomorrow, and there's community members who are submitting,
Yep.
planning to submit for that. And that's the only one right now that's on the horizon. Oh, and also Terry is looking at submitting something as well for a different conference.
Yep. Yeah, so we've got a number of other potential possibilities here, and it's really up to for the ones that we have to travel to. It's up to it's going to be up to the community because we are on a travel pause. But many thanks to all the folks who have volunteered to help move these things forward. These particularly the two that were just mentioned. There's been a lot of effort there in getting that in. So thank you all for doing that. It's really inspiring to have the folks from the community helping out there. So that's great.
Yeah, and I'd also add that if anyone on the call or in the community is planning or knows of conferences in your discipline that's an opportunity to submit something with PACIO, please let us know, because we have previous posters and abstract Word documents that we can use to build a submission with you. So if there's any opportunities that you'd like, please reach out to us and we can work on coordinating. And thanks to all of you so far who've reached out for potential opportunities.
Yeah, it's been great. Great to see. Thank you. Thanks, Uba, for coordinating all this. I just wanted to mention the MITRE playbook, H playbook. It is now available on hplaybook.org. It's been a bit of a trial to get it going, actually up on the domain, but it's there now. So you can take a look at it. This is basically talking about how to start with a concept, create a community, get through the standardization process, testing, and implementation, and then and eventually adoption. So MITRE is hoping that this will be something that is educational and helps scale the efforts that this project and Codex and various other things that MITRE has been involved in, to capture the best practices that we've used to make these things work and to share that with everybody. So that we can scale this and address even more aspects of health interoperability. So check it out. PACIO is covered as a case study. Feel free to send me comments on it and let me know how you like it. And that's it. And I'll pass it back to Yolanda, unless there's any questions.
Thank you so much, Dave. I believe, Shelley, the question about Ahimia, it is a presentation, but Uba, can you confirm that?
I'd have to go back to the original spreadsheet. I can get back to you, but yeah, the Ahimia, that's for the Health Information Management Association.
Mm-hmm. Yeah.
I can get back to you on that.
Thank you. Yeah, thank you so much. All right. So let's move on to our subgroup updates, and the subgroup lead, Elisa and Jamar, both of them are in the AOTA conference this week. So we are excited to hear back from them when they come back, and we'll help them to present their conference experience. And for the PFE subgroup, I will have Uba to provide the update for the subgroup.
Yeah, thank you, Yolanda. The PFE subgroup today met with James Patterson to go over medication administration related data elements for the USCDI V6 comments. So there was more discussion around there and came to consensus about how to move forward next on coming to a PACIO-wide consensus. And so after that discussion, we kicked off the start of STU3 work in earnest. We spent the past couple months or 3 months going through potential topics and potential existing resources that we can build on. And we've settled on actively working right now on reviewing an existing resource for ordering equipment, and with an eye specifically on expanding its capability to support PAC settings, as well as include data elements that would support reimbursement, not including data elements that are part of the reimbursement itself, because there's a resource already for that, but capturing information that's critical to support reimbursement. While that work is going on, the PFE leadership team in the background will be communicating with implementation guide owners for profiles related to behavioral health and discharge summary and environmental factors, and reach out to them to see if we can collaborate, as their profiles are currently in development. So the suggestion from Dave was to work with them on incorporating feedback from us while they're in development versus us creating a PFE specific profile. And then, so that work will be going on in the background while we're actively in our weekly meetings working on ordering equipment. So if any of you are interested in joining those conversations, we meet Wednesdays at 11 a.m. Eastern, 8 a.m. Pacific. And so we'll be working on ordering equipment over the next at least couple weeks. So that's it for me, and passing it back to you, Yolanda.
Thank you, Uba, for providing the update for the PFE subgroup. And next up, we'll have James and Terry to provide the TOC subgroup update.
Sure. Terry, did you want to go ahead?
No, go ahead, James. You're on.
Okay. Just the kind of ongoing work to get the IG published for ballot, that is. So we've been going through the final throes of getting the IG finalized and through all of the quality reporting requirements. So we, with lots of help from Dave, able to get through all of those efforts. We've been through the patient care work group and the fire management group to have all of the IG approved from content-wise and standards-wise, and standards being quality assurance wise. So we are good to go with our ballot for May now. So that's been published, and we'll get into the balloting process here shortly. I believe that starts in later in May, or later in the month, just before the May meeting. But that's the major updates. I guess the one other one, and you might talk to this a little bit more, Terry, is we are going to have a patient advocate go through and take a look at the DEL and put their insights onto what they think is important in the transitions of care data elements, so we can start understanding that more to ensure patients are engaged in this process as well. Did you want to say anything else about that, Terry?
Yeah, I mean, transitions are really interesting. The groups that we've focused on, nurses, physicians, dietitians, therapists, pharmacists share a fairly broad set of data elements that they use quite commonly. So there's more overlap among those groups than the next series of groups, which really have different set of data needs. Patients and their caregivers being one, and then probably behavioral health as being a second group that's going to have many data elements that haven't been called out quite yet by the first groups going through. So I think it's not only will they find things in the DEL that the other groups didn't necessarily feel were important, but they're also going to add data elements that are not in the DEL that they think are essential. We've done that for the other groups. They are not in the current ballot, but as we discussed earlier, we're going to probably add them when we get the comments on the ballot, because the two data sets, what's in the DEL and what's not in the DEL, are what constitute a complete data set. So we've got the DEL elements. We're going to have to get the non-DEL in at some point. That's it for me. Thanks. Thanks, James.
I think that covers it for right now. Back to you, Yolanda.
Yeah, thank you both, James and Terry, for provide. Yeah, a date is there? Okay.
Yeah, it just was so the ballot opens on April 4th, and so it closes on May 4th. So that'll be the time period where we'll be receiving comments. I'll be creating a dashboard to so that, we can see what's going on there with the ballot. And we'll see how it goes. So you need a 60% approval rating. So if there's, say, 100 voters, you need 60 affirmative votes to get it approved, and get it through ballot. Otherwise, you have to go back and convince people to remove their negative votes. So we'll see how that goes. And this will be the first time we do this, so we'll see what people think of it. And so eager to get it out into the wild.
So
Yeah.
Dave,
Yeah, go
Yolanda,
ahead,
sorry,
Sally.
just a quick question. So the potential of the patient perspective, is that incorporated at all just yet in what's being posted for ballot?
No, I'll answer, Dave. The answer is
Okay.
no, Shelley. We've just started on it. So I think
Okay.
that's going to be a major piece of work coming up.
Yeah, it sounds exciting. Be anxious to hear more about that.
Yeah, it'd be interesting. And also sort of who should we recruit and how do we find folks? And so just out to the entire PACIO community, if you've got patient representatives, family members who've been involved in multiple transitions, someone who might be interested in helping us think through what the important information is to have, let's hear from you and hear from them.
Yeah, so there's this is kind of the items that we cover right now in the transitions of care. So there's 16 different sections here. That's these top level blue items, the advanced directives, allergies, behavioral health, and so forth through vital signs. And so the patient perspective would be potentially a new section in here.
And maybe this doesn't fit, and I don't know that we need to get into this big conversation, but do you see it as an element along these things that already exist?
Yeah, I mean, and there's some cases where it might not, it might these things might be incorporated in some of these already existing sections, so it's not necessarily a given necessarily that there would be a patient perspective. Although I think it's highly likely it may happen here, but there's things that are intermixed here as well. So, for example, in plans of care plans, there's substance abuse under social history, and there's a behavioral health care plan under behavioral health. So things kind of get intermixed. So it's just a matter of what this is really trying to specify is where things should go.
Yeah.
So
Has there been any, see, you definitely touched a nerve for me, right? So I'm going to stop after this. But has there been any thoughts about like the 4Ms or the age-friendly health system or any of those sorts of things that, kind of exist out there that have been kind of focusing on some of that stuff?
Well, Shelley, I'm part of the Moving Forward Coalition, which is um, the Hartford Foundation
There
supporter,
you go. Okay.
or am baked through and through. So it's finding its way into all of this. Yes.
Okay. I'll engage in more conversation later, but we'll go on for now. Thank you.
Yeah, we're very fortunate to have Terry and help leading this effort along with Holly Miller. They've been thinking about this for quite some time, and was the basis of this works. The stuff that they've done in the past was a basis for this work. So
Great. Thank
any
you.
appreciation for them on this.
Yeah, I think I'm thinking we are talking about from acute to post-acute, and if you think of the reverse order, if you transferring from home to the hospital or the different care setting, the patient perspective could be important, or the caregivers, their input could be valued for next settings of the care. As we are just touching the STU1, so we are just putting all the most important essential data elements in the IG for now, but definitely we are, as an IG developer is being developed throughout the course, definitely we could incorporate more different groups and a different perspective. All right. Thank you all very much for the discussion. And next on our agenda is our continuation discussion of the USCDI V6 comments. And I will pass it over to James to lead the discussion.
James, if you're talking, we can't hear you. I think you may be muted.
I am definitely muted. Thank you for pointing that out. And Confluences. Sorry, I was just trying to get the link into the chat window so everybody can pull down the comments if they so would like to take a look at the full details. So I'm going to go through and kind of cover what we talked about before. That's down the bottom, the approved things. So we'll be submitting these 7 data elements that we had previously talked about and previously had submitted that had no major changes. Those are all set to go forward. We're going to be reviewing our 4 data elements that we've put in before but have some decent changes. Major is a relative term, but we needed to have conversation and discussion around those. And then we have 5 comments, which I don't expect all of them to go forward. So we might kind of vote on those in blocks, or we'll see where the community is as far as agreement towards the end of the meeting and figure out the right way to push forward with voting. So without further ado, real quick summary, the 7 comments that we're putting forward that we've put forward before: the disability status, some different vocabulary additions to the functional health status, health concerns, and mental cognitive status, advocating for a couple of new things to be moved forward up to level 2, at least, if not all the way to USCDI, for nutrition status and order. Device use, we're moving forward with still. And then the portable medical order for life-sustaining treatment, we're recommending be removed in favor of the portable medical order data element that's been accepted. So that's just a quick review of what we've already said. Yay, verily, we're moving forward with. This is the last kind of review of these data elements, so hopefully we'll not be discussing these again anytime soon. But we're gonna go through them real quick, and then we'll do a quick vote to make sure the community's all in favor. The ones that we have changed, and why they've changed. Advanced directive, the previous recommendation was to move forward with this as a data element. It kind of got moved around over the last several iterations of USCDI, and we were advocating for it to kind of get reset again. The community had basically said, don't submit any comment right now. That data element's not sufficiently developed, so we're going to wait to make any more recommendations until we have a much cleaner way forward. It's officially out in standards like the ADI IG that we're working on, and then we'll come back to that. So basically, we're retracting that comment and will not be submitting it. The second of the ones that we have submitted in the past includes the purpose of capture. Our previous comment was to promote either purpose of capture or rationale to level 1 to better align with CMS and the HIT work group, who are submitting a comment that's promoting signature and purpose of capture. Our comment, we've restructured it to just be focused on promoting purpose of capture to level 1, and just leaving rationale as level 0 and kind of ignoring it for now. So we've just restructured it to be specifically about the thing that we want to happen, and have left out the other part. So any questions on those before we move forward? Okay. Please feel free to go back at any time. I just don't want to hold people too long waiting for somebody to come off mute. The third comment is the patient communication status. Previously, we have asked for the patient communication status to be renamed to just patient communication, which is essentially an attribute of a patient, and then have it also moved from the health status data class to the patient demographics. Based on the communication recently, we are just asking for the current patient communication status to move forward as is from level 0 to USCDI V6. And there's basically a community consensus that, or community feeling, we're going to get to consensus hopefully shortly. There was a community emphasis that the status was really important to be able to capture at any given point, and that was still necessary. So we've changed that comment to be just moving that current status forward as is. Any questions on that? And then the last one, and I will note that the 3 of 3 was slides, not of comments. So there are 4 comments that have been included here. I was just noticing that might be confusing. At any rate, the portable medical orders is the current name of it. We have been advocating for it to move forward to USCDI V6, but also rename it to just be portable medical order in the singular, so that each record represents one order. The note here is that it has been accepted in that fashion into USCDI, the draft of USCDI V6 that came out a little while ago. The comment that is being recommended to be submitted this time, though, includes an addition of updating the description and what the data element represents. The conversation within the community up to this point has been that there is not a firm enough definition across the community about portable medical order, and that it is all structured everywhere that it exists. So this is kind of rolling it back a little bit to make sure that we're sure we're able to capture portable medical orders as PDFs or as other artifacts, and can also represent what that artifact means as far as what should be done as far in treatment going forward. So the rationale kind of breaks down what was requested and what the discussion was, as far as the description of portable medical order was too narrow, being primarily focused on only end-of-life things, instead of the full array of what can be captured in advanced directives and portable, and thus in portable medical orders. Sorry, I probably made it too narrow again by saying advanced directives. So, but the other parts of this are just acknowledging that there's not a current standard a current IG or way to reference the structured data. And that we want to make sure that it includes all of the unstructured data and the intended scope of those within the intended scope of the data element that's being approved into USCDI V6. So hopefully the intent is that the new comment will help structure that properly and make it broad enough to capture the things that are currently being transmitted within US Core and CDA, and kind of gives us a way forward as far as having all of that data pulled in, but not being too restrictive. Any questions or comments before we move on past this one? Okay. I'm actually going to break this up into this chunk of 4 data elements and our way forward on those, and vote on this, and then separately we'll talk about the new ones and do a vote for the new ones at the end of after we discuss those. So I've got a cheater down in the notes there. So I'm going to put forward, or sorry, I'll before we vote, and now that you all know that we're going to vote on just these 4. Does anybody have any questions, comments, concerns, anything they want to air at this point? Okay, taking silence as concurrence. So I'm going to go ahead and put forward the motion to approve all 4 of the previously submitted PACIO comments with the updates and changes for this commenting cycle.
A motion has been made. Is there a second?
Second, Terry.
All right. Thank you, Terry. Thank you, Michelle. Any further discussion? Hearing none, we'll proceed with the vote. Anyone wish to abstain? Anyone opposed? All right. The motion passes 16-0-0. Thank you.
Okay. Thank you, everyone. Getting close to getting this all knocked out, and we can move on from our comment cycle hopefully soon. They are due very soon. That's why we're kind of pressing hard on these now. Okay, as for the new data elements, we have 5 of them, and there's 1 per slide, so there's no confusion on this set. The first 2 have been presented a couple of times now, so hopefully we've got these locked down and everybody's comfortable with them, but I'll go over them real quick. The criticality data element that's associated with the allergy and intolerance class, we were requested to review a couple of these by CMS, and our community has gone through and looked at and given feedback that yes, this data element is critical, and the really kind of critical part of it is the combination of, and that makes it real hard to read, so I'm going to highlight that again. The combination of the criticality data element along with the allergy or intolerance agent, as well as the clinical manifestation being the reaction, those 3 things all together are really what is critical to understand when a patient is being seen and trying to address anything that they might need for avoiding allergies, avoiding medications that might cause problems. So 2 of those already exist in USCDI. The criticality data element is the one that is missing. So our community is saying that we support CMS's recommendation for this data element to move from level 2 into final USCDI version 6. And there's a little bit more language in there and the applicable standards. Does anybody have any questions or comments on that? All right, please feel free to jump back if I go too quick, but we'll move on to the next.
James, I just want to, this is Lorraine, and I'm not going to take time on this call, I'll get back to you. I mean, I totally agree of the critical part of what the data elements are capturing, but criticality seems like a weird terminology within, I don't know, to collect all these, but keep going.
Right, so
yeah.
So when reviewing this, the severity is when the event itself happens, but criticality is kind of the future outlook of it. So that's the kind of well-established terminology that goes along with allergy and intolerance. Does that help?
I'll probably have comments for you, but keep going.
Okay. As we were going through and doing this review, one of the people that submitted that was helping provide the comments also noted that it would be important for the drug class allergy intolerance to include an additional terminology. So specifically, this is asking for medication reference terminology to be added as an applicable vocabulary for that data class, or for that data element, excuse me. And so there's just a little description here of adding that data class and what we get. It does include the existing three standards that are currently included for this data element, but kind of wraps that in the larger terminology set that is available. Any questions or comments on this one before? Okay. These are going to be our two foundational ones. I feel like they're ready to be voted on and everybody's going to confirm them. The next set is we've gone back and forth a fair amount, trying to get down to the point where we have a good path forward on medication administration and how we represent that within USCDI. I'm going to touch on these real quick, and then I'm going to go to the last one because I think that's where we might have found consensus. We met with the PFE group this morning, bringing forward SMP's recommendations, and now we can catch up with Terry for TOC and everybody else that's involved today to see if we can come to consensus. But there's a set of medication administration data elements that were being requested for a review by our community, including code, dose, and reason for reference, which approximately equate to code is the medication itself. Dose, of course, is the same. And then reason reference is approximately synonymous with indication. The last one being at a different level and represents the patient is also synonymous with the regular patient record, not just a medication administration patient. The feedback we got last week and previously from our SMP group is that these are largely redundant and could be taken care of in a better way. So we've gone through and understood how they were looking at this moving forward and looking at what can be done to make that happen. And ultimately, the thing that SMP had brought forward and the pharmacy community had worked on is this concept of the medication list type and a medication list representing medication administration. So to avoid having to duplicate those data elements for every different kind of list that we might want to make, the medication list type basically allows the group of medications to be identified and grouped together so that you can say, okay, this list is for those that have been administered. These are the active drug list. This is, I'm going to forget, so I'm going to look at the discharge medication list, active medication list, and transfer medication list. So there are a variety of lists, a variety of identifiers within the medication list type that can be used to indicate what it represents. In essence, allowing even the medication administration report to be adequately covered within the current data elements. The conversation this morning's PFE meeting was that this should cover all of their needs. I know this is a quick look, Terry. If this is the case, does this cover the needs you believe exist in the transitions of care community?
Yeah, it certainly sounds like it, and sounds like it's cleaner. So that sounds fine.
Okay. So I'm going to open the floor now for conversation on the medication list type, as well as the medication administration data elements that we talked about earlier. just to get folks feedback and kind of see where the community lies on consensus on a good path forward. The current path forward, I think, is the recommendation is to not submit the other two comments being medication administration, but submit this comment advocating for the medication list type to be included.
Yeah, James, this is Terry. Yeah, I think as long as in a sense, the data, so the indication who it's going to, the dose, as long as that's clear, then the structure, how you ultimately structure that information, is less important than the fact the content is there. So
Okay, perfect.
I think this certainly makes sense.
Anyone else? Okay. If folks are comfortable, this is a brand new comment that was just created today. So if folks are comfortable, I will propose that we submit this one and the two allergy and tolerance related comments, and we can close out our commenting period. If you feel like you would like to take more time to review this this comment on the medication list type, I'm happy to come back and we can approve the other stuff, approve the other allergy ones, and then come back and vote on this one next week as the final one-off vote. Is there a preference anywhere from anyone?
I'm okay with these submissions.
Yeah, why don't we do it today if we can?
Is anyone opposed to doing it today?
No objection.
Excellent. So I will make a motion to approve the three new comments regarding allergy intolerance and the medication list type for this comment cycle.
A motion is made. Is there a second?
Second.
Thanks, Lorraine. Any further discussion? All right, hearing none, we'll proceed with the vote. Anyone abstaining? Anyone opposed? The motion passes 16-0-0. Thanks.
All right, thank you, everyone. I appreciate you sticking with me through all of these different iterations. I think it's a testament to the community that we've been able to discuss and come to consensus and get all the way through this process. Thank you all for your time. I'll turn it back over to you, Yolanda.
Yeah, thank you, James.
Yeah, very well said, James. I think this is another round of the community efforts and team efforts, and we go back and forth and back and forth. But finally, I think we get a consensus from the community. This is how the whole PACIO project works. That's wonderful. It's I'm so glad we made so much progress today, and thank you all for the great discussion. And I think we went through all the items on the agenda. Is there any walk-on topics people want to talk?
I think
Discuss?
May had maybe an interest in providing an ADI update.
Sure. Yeah. Go ahead, May.
Yeah. Thank you, Yolanda and everyone on the call. So yeah, since I'd be happy to present it on behalf of Maria Moen and the rest of the ADI team. We've been proceeding really nicely and actually completed on the review of Maria's environmental scan, which basically did a cross analysis of over 80 portable medical order related documents across the 50 states. It was quite a task. It included the needed codes that would be, potentially either reorganized inside VSAC or potentially requested for new loin codes and so forth. Now that we have gone through the environmental scan, we have further synthesized them into 7 major kinds of enhancements that we firmly believe would make an impact for the Advanced Directive Fire IG. That would include the representation, a little bit more detail of CPR orders, personal goals, decisional capacity, and I think very importantly, the notion of jurisdiction, especially as we were going across the 50 states. The relevance and importance behind that is that given that patients can have changes in between states, the notion of knowing the differences among both and its implications becomes very important, and that has been a focus for the past couple of times that we've been meeting. All of this is now helping to inform some of the changes for our STU2 ballot, which we are still targeting to have for this September. In the meantime, we're also pushing on resolving and getting consensus on the existing tickets that we have within ADI. We have a block vote 2 vote that we are working on that currently has 25 issues with proposed resolutions on it. So we are making some pretty good progress here, not just for the semantic interoperability aspect of codes, but also for a better alignment, not just within FHIR, but within its equivalents in CDA. Giving some due credit to the results and the feedback of this work that has been helping to inform USCDI, which James had talked about before. And I think that's the status for ADI. Any questions or comments? Okay, well, back to you, Yolanda. Thank you.
Yeah,
Thank you, May.
Thank
Yeah.
you, May, and thanks to Maria for leading this effort. Great work.
Yeah, absolutely. I think the ADI group is like a meet every 3 times every week. That's a lot of work, and it's
There's a lot of commitment from
yeah, definitely. All right. Lorraine, go ahead.
Yeah, I just have one update. I just wanted to let everybody know that the latest that I know is that CMS is still going to have their Connectathon in July 15th to the 17th, and it is slated at this point to be in person. So if we have any tracks that we want to go forward, just kind of let me know, or Dave, you can reach out so we can let the team know as well.
Okay, yeah. When do you need that?
I'm not sure yet. I think they're trying to get the information out, but because of the communication freeze, they've kind of been on hold. But I'll reach out and see when we need that, but I know probably sooner than later.
Okay. Great. Thank you.
Yep.
Yeah. Great updates, Lorraine. Thank you. And we are actually thinking about the planning of the July Connect Zone already. We'll be in touch. All right. Anything else from anybody? Here none. And thank you all very much for your contribution to the PACIO community. Dave, do you want to say the words you want to say? We cannot do it. I would just say it for Dave. We cannot do it without you.
Yeah, I'm sorry. Yeah. No. Thank you, everybody. We would not be able to do what we do without you. You all bring your own secret sauce to this and help scale this activity. And we really could not do it without you. All of the expertise that you all bring. So many, many thanks.
Yeah. Thank you all. And I wish you have enjoy the rest of the day. We'll see you next week.
Thank you.
Bye.
Thank you.
Thank you.